Quick PSA for all my girlies with DOR or diminished ovarian reserve who've been told they have a low AMH in their early 20s or 30s. There could be an underlying reason, and sometimes knowing what that reason is might change what you do now and how you think about your reproductive timeline and even the potential future health of your children. When I see patients with an unexpectedly low AMH for their age, I will often screen them for something called fragilex mutation. This is actually a gene mutation that involves a 3-letter section of the genetic code on the X chromosome, and it can get duplicated many times. And if there's over 200 times that it's repeated, that's the full-blown mutation, and you're actually affected and will have clinical manifestations, especially in men who only have a single X chromosome. But occasionally, you will have women with full mutations that have little or no effect because they have another X chromosome to compensate. But you can also have something called a premutation where you have less than 200 repeats, but it's still a lot. So it's like 55 to 200 repeats, and this is called a premutation. And I pick this up a fair amount, and I will test patients for this if they have a lower ovarian reserve than I would expect for their age, because there's a strong association between having a fragile X premutation and going into premature menopause. So I have an actual real-life example of a patient I've been taking care of who's 30 and has an AMH of 0.2 nanograms per milliliter. This is much lower than what I would have expected. So we did fragile X mutation testing along with a host of other tests to look for underlying risk factors, and we found she had a premutation. And this is what I told her. Let's be aggressive. Let's freeze your eggs now, whatever eggs we can get to. I know we have a limited supply that we can access in any given cycle, but it is what it is. Let's try. We'll get a small number each time, but it's worth it because given your young age, the quality should be good. And hopefully we won't need that many to make healthy embryos. And because you've been identified to be at risk of going into early menopause, I often talk about how low AMH levels don't define your fertility, but if you fall below a critical threshold or a certain number of eggs, eventually your ovaries will stop functioning and you'll lose the ability to ovulate or release eggs. And that means no amount of medications I administer, no treatments like IVF at that point will get through to the ovary and be able to stimulate it to access the eggs. So you want to strike while the iron's hot. If you still ovulate and you have low ovarian reserve, but you have some follicles there, let's do this thing. So in this particular patient, we've now done several rounds, at least 3 rounds of egg retrieval, and collectively we've been able to get around 15 eggs, which is actually amazing for someone who's 30. Now, do I know for sure when this patient's going to go into menopause and run out of eggs? No. Do I know that this is going to happen to her for sure at an earlier age? No, but I have suspicion of that. And now we're in a position that even if she does, I can still turn those eggs into embryos and try to use them to get her pregnant. Even if her ovaries stop functioning, I know that I can get her pregnant if she has frozen eggs. So if someone doesn't have previously frozen eggs or embryos and they're in this situation, really the only option at that point when the ovaries aren't functioning is donor egg. So this is why knowing that there could be an underlying genetic cause or a risk factor for going into early menopause is so crucial to understand the urgency and importance of egg freezing now. I want to mention that this patient met with one of our genetic counselors because it's so important to understand that with this type of mutation, you might have the premutation, but this can expand into the next generation. So her children will have a certain level of risk of having the full-blown fragile X mutation. And the number of triplet repeats that they themselves carry in their premutation will determine the risk. So for example, if you have 85 repeats, that's on the higher end versus having only 56. So in that case, you can expect around an 80 to 90% risk of having the mutation expand into the full mutation when you have children. So this is so important to know in advance, and also presents an opportunity if the patient wants to one day down the road create embryos where she does PGT-M to test for fragile X and avoid having a child with the actual syndrome. This can also be tested for in pregnancy. So this is a really specific situation, but you'd be surprised. I've diagnosed a number of young patients that have DOR with the fragile X premutation. So this is definitely something to ask your doctor about if you're in this situation. Stay tuned for an upcoming video where I'm going to talk about other predisposing potential risk factors that can cause DOR at an earlier age than expected, not just genetics, but also gynecologic, autoimmune, and even environmental.